You're watching Beyond Markets. Welcome. I'm Esther Awoniyi. Many thanks for joining us. On today's show, we'll discuss how to improve health outcomes in Nigeria. As always, you can join the conversation with the hashtag Beyond Markets, and you can follow and send tweets to my Twitter handle too. It's at Esther Awoniyi. Now, the World Health Organization says approximately 4 out of 5 cancer cases result in death in Nigeria, one of the worst cancer death statistics in the world. However, the WHO says between 30 to 50% of cancer cases globally were preventable. Dr. Adedayo Onitilo, Service Line Director at Marshfield Clinic Health System, joins me now for today's discussion. Dr. Onitilo, thank you so much for joining us today.
Thank you for inviting me.
Now, we're looking at health outcomes, improving health outcomes in Nigeria. And at the beginning of the year, I spoke to a number of health experts, and they talked a lot about what the expectations were in terms of how to improve healthcare in Nigeria. We talked a lot about, improving primary healthcare, the first point of contact, especially for those in the rural areas. We talked especially about private sector engagement, because you and I were talking earlier about the funding gaps in the healthcare systems. I mean, we're at a time where African governments are cash-strapped. I mean, you look at the annual budgets, and instead of key, sectors to receive increased funding, education, health, we're not seeing that happening. So obviously, this has brought on the conversation for the private sector to get on board. But it's one thing to want the private sector to get on board. It's another thing for you to be able to actually provide a conducive environment and the right environment still to bring, attract that private capital. That being said, I'd like you to share your thoughts with us. I mean, you're here in Nigeria with the team. We're looking at today, focusing on cancer treatment, early diagnosis, care, long-term care. You're here to look at the Lagos University Teaching Hospital. Talk to us about your visit, why you're here, and then we'll take the conversation from there.
So this started about 2 years ago when I came for a guest lecture for a gala that was organized for LUT, for fundraising. And at that time, I promised Professor Bode that I'll be back in the country. And he took on that challenge immediately. And we set up a WhatsApp group where we have almost 30 people, and we've been communicating even from the standpoint where equipment have been procured. We were providing some technical support and dialoguing at that point in time. And once the equipments are here and the center was about to start with the specialists we have on ground at LUT, Professor Bode reached out again that our group be able to come. And I was able to organize a group of 6, including radiation oncologists, physicists, radiation therapists, a dosimetrist, and a PhD nurse practitioner, and myself, a medical hematologist, as well as an oncologist, researcher, and administrator.
Okay.
Our visit has been remarkable. It has really shined a lot of light on things for me, especially. My expectation coming is completely different from what I've found here. The people are very eager, they are very receptive, and our training as well as our experience has been very positive. I really would like to thank LUT administration and NSIA for this opportunity and for the vision to do this. I think history will be very kind to them. The
NSI, that's the Nigeria Sovereign Investment Authority.
Yes.
Okay. Now, let's take a few steps back, because we know the late cancer detection is an issue in Nigeria. There's also the stigma, the perception that anyone who's been diagnosed with cancer has been given a death sentence, and that's because most times there's been a late diagnosis. Yes. And it's mostly too late, for anything to be done. So that proves, the stigma that, you've gotten cancer, then that's it.
Yes.
But hopefully that is changing with this equipment that we now have in the Lagos University Teaching Hospital. But talk to us about, the journey to get there in the first place, because this is something the country has needed for a very long time. Statistics, unfortunately, many times are not exactly accurate. We cannot even put them together. We have one from the WHO. I'm hoping that, it's up to date, but we're not particularly sure about the exact number of people who are being diagnosed, those who have not even come forward. So, it's a bit of a mess. But for you, how we're managing cancer in Nigeria, early detection, could you just speak on that point, early detection, and the kind of capacity that we have to handle it?
So you nailed the nail on the head. You hit the nail on the head by mentioning that we have the sobering statistics of 80% people that are diagnosed with cancer in Nigeria are dying of cancer because of late diagnosis. That is anywhere in the world that you have cancer diagnosed at very advanced and late stage. What we need to do is not going to be solved by equipment and specialized physicians. You talked about the primary health care, and the government, I know, are doing different things targeting primary health care. In fact, if you go back to primary health care that was laid down and legacied by Professor, the late Olikoye Ransom Kuti, that was the health minister then. You have the master plan and the template for primary health care in Nigeria that will work for Nigerians, well laid down. And when you're talking about cancer, there are international screening guidelines that can allow people to be diagnosed at a pretty early stage. So you have guidelines for breast cancer screening, which is probably the #1 prevalent as well as morbid cancer in Nigeria, for example. We have to work, knowing our own culture, we probably have to work with the churches and the politicians and hairdressers through community engagement and community outreach, spend money on screening. For men, prostate cancer is largely very prevalent still, and we have screening for that. You have to do screening for prostate cancer. Colon cancer, there are screening guidelines that can be tailored even for the Nigerian population. If you don't, colonoscopy is what is done mostly in the rest of the world, and these are to be targeted to certain age group, age bracket, and you have frequency for this screening. I don't want to rehash the various age at which you start screening. Cervical cancer is almost eradicated in many parts of the world because of screening, early diagnosis, and treatment, and we're still having people presenting at stage 4 cervical cancer, and it's pretty much cervical screening, pap smear examination that you do. We don't have a lot of melanoma locally, but skin screening is the type of screening that you do for that. So if we can put in place good screening and primary care program, that will go a long way, even educating the public.
I was going to come to that because many health experts that I talk to always say, look, these facilities to a good extent are available. It's the awareness. People do not know when they're presenting certain symptoms. And obviously there are other economic issues. I mean, affordability. When we talk about universal health care, that's still something we're having a conversation about here. Many Nigerians, I mean, the way our healthcare system is structured is out of the pocket payment. And so and I was just looking at how much it costs to even go for a woman who has breast cancer for treatment between 2.9 to as high as 29 million. And I'm saying, who can afford that? So there's so many moving parts, but I know that obviously these challenges are not unsurmountable. We can, we can tackle them. But in your opinion, how do we ensure that all the parts are moving in the same direction and coming together? Education, awareness on the one hand, making sure that people have access to the right care and that they can afford, it's affordable to, affordable to some extent, and ensuring that we reduce the numbers.
There are multiple things you have said in your conversation. It's just, it makes my brain go this way, that way, so I'm going to try as much as possible to keep it straight. They say our people like to, we talk in parables and parlance as Africans, that a stitch in time saves 9. And some people will say that, failure to plan is planning to fail. if you are worried about not spending 2-point-something million naira on treatment, we all know that prevention is better than cure. Then you do screening. Screening is cheaper. So a mammogram, for example, in some of the places that is available, when you're doing it at the regular interval, probably costs 10,000 naira or so. I know that's what it costs. And if you detect it early and you have a surgeon remove the lump, you may not even need the morbid treatments that come afterwards and are not even curative. They are mostly palliative. That's why you have the 4 in 5 people with cancer dying of cancer. So we need to start educating the population. And when we say educating the population, now we start the way, for example, in most parts of the world, the best people to educate the population are our musicians. Our musicians and our celebrities on different, they should be part of this also, not just government. In fact, we should stop thinking about government doing everything. We are government ourselves. We are in a democratic system of government, and is system of government by the people, for the people. That's democracy. So we should be part of the solution, everybody. Everybody doing their part. Not just the government, government can't do everything, let's be frank. So the private sector should be part of this effort. The churches should be part of it. In fact, if you look at the 3-legged stool that religion came to Africa with, it was education, health, and what's the third one? I believe philanthropy is the third one that they brought. And these days, religion is just, and the spiritual, of course. I shouldn't have left that out. So it's education, they are catering to our education. They brought the religion itself, and then healthcare. And where are the religious organization now? They have a lot of money. In fact, if you look around, you see that the richest churches in the world, the richest pastors in the world are here in Nigeria. So we should have the best hospitals too, if you go by that token, that they can be well funded. So the private sector, the churches, the government, the people themselves, I think we can do this.
Dr. Onitilo, we're going to take a short break. Thank you for your time so far. We're going to come back and pick up from where we left off. I've been speaking to Dr. Adedayo Onitilo, Service Line Director at Marshfield Clinic Health Systems, and we've been discussing how to improve health care outcomes in Nigeria. If you're just joining us, Dr. Adedayo Onitilo, Service Line Director at Marshfield Clinic Health System, is with me today, and we're discussing how to improve health outcomes in Nigeria with a focus on cancer treatment and care. Dr. Onitilo, thank you for your time so far. Let's pick up from where we left off. We've talked about issues around awareness, but more specifically, getting more private sector involved. And back to this, the Lagos University Teaching Hospital, while you're here, the team that you brought with you, we're talking at the beginning of the show, your observations. And perhaps you can share further details in terms of, where do we go from here? You brought your team and you were impressed with what you've seen so far, but there's still issues around capacity building, training. Could you speak to that point? Perhaps we can do more in terms of properly equipping our health professionals here to especially around cancer, because I know it can be quite specialized.
So specialist care, and it's not just in oncology, need to improve generally. We have very bright doctors in Nigeria, well trained, but I believe we need to stop thinking actually about US standard or Canadian standard. We need to start having Nigerian standard that it will be international standard.
How do you mean?
So somebody in US is not going to say Nigerian standard. They'll say US standard. We have to be patriotic, passionate about what we do also to establish Nigerian standard. And the Nigerian standard should be good enough that it will be international standard. We are part of the international community. So we need to start, of course, upgrade our education all the way from primary to secondary to university level. Many people came to Nigeria in the 70s and 80s, and they will choose to come to Nigeria than go to some Ivy League universities abroad. But that is changing, and we need to reverse it. Now you have Nigerians that trained in that era, and in my era, leading and are top-notch wherever they are in the world. We might think that we have lost 2 generations in a swoop. Our generation, for example, out of about 70,000, I may not be giving you the exact code, but it's close. Doctors trained, about 35,000 are practicing around the world, and they are doing very well. And if you look at statistics every day, in Ivy Leagues all over the world, in UK, in the US, the top graduating students now are of African descent and Nigeria. Those are our children. But I think this is good for us, because we are not going to have brain drain anymore. We should start using the term brain gain. Because
well, I don't think the conversation has flipped in that direction, because what we're still discussing about here is brain drain. I mean, the doctors, some of them are trained here initially, but then they go abroad, they get further training, but they don't come back. And we see all kinds of specialists abroad that can be useful here, but they don't come back. And here we're still grappling with issues of inadequate training and capacity building. So it's a problem.
we are in the digital age. You don't have to be somewhere physically all the time to exert your impact. And those of us that have trained everywhere in the world, not just US, Canada, Australia, some of us, because of our children in school and things, we cannot physically come back. Not everybody. Some will, because there is no place like home. Some will come. And I know, only Nigerians are going to solve the problem of Nigeria. Only Africans will solve the problem of Africa. Other people will help us, but we have to organize and solve our own problems. So our children, ourselves, that have trained in very good schools around the world, we are going to have to bring them back. The government will provide, and I know the government is doing stuff on diaspora things. They are trying to provide the environment. Like myself coming back to Luton for the last 2 weeks, I believe the reception that we receive is exceedingly important in us coming back again. And I'm so motivated that I will probably continue to sustain this.
Yes. But how did you feel? I mean, what you saw on ground, I mean, the level of training, the level of capacity, and the gaps that still exist. I mean, how do you feel about that?
Well, I feel that the moment someone thinks that I have arrived and I have all the training, then the world is going to move past you. Training is a continuous thing. Even for you, even for anyone practicing anywhere in the world, you keep upgrading and updating. That's why you have version 1, version 2. So what we have now, we cannot thumb our nose at it or look down at it. It's what we have. And between that's why I said the Nigeria standard, the Nigerian way, and we're going to make it international. So with what we have on ground, which some of us are not exposed to, and the training that we have there, Nigerians in diaspora and Nigerians locally, we just have to marry our experiences and our knowledge to create the Nigerian experience that will work for Nigeria and might even be better than what some people are grappling with around the world. We already know about the religious influence on healthcare. We already know about the issues that surround things. We can deal with that. If we can deal with that, I'll tell you, people think that it's equipment that is going to improve healthcare. It is big doctors, it is big name professors like myself. No. Sometimes it's just organization. A patient can come into a place and just the cleanliness, the way they are dressed, the orderliness in that place, they already feel that they are like 80% well. So we need to get that on ground. We need to be organized. We need to be punctual. We need to have professionalism. And then the rest of the world can start emulating that, and we can have, and then in terms of the training you're talking about, that will come. That some of them you already have training here, you already have some, but we need to continue that on a steady basis.
So for you, for this visit, I mean, what are your visit is almost over. What are the conversations that are happening right now in terms of how this could continue, if possible, transfer? Because I know that it was all about transfer of knowledge, right?
Yes.
Transfer of skill and knowledge. I mean, how is this going to go in the future? Is this going to be something that's going to be continuous, or what do you foresee? What's been talked about right now?
So this is going to be a continuous effort. At the end of this, I'm going to write a comprehensive report, and I'm going to sit with key stakeholders. And that is another important thing that this visit is unique in terms of that they gave us the free hand. They provided love, and I know that whatever I recommend, they are going to act on it. It's not just going to be a propaganda. And one of the things that we are going to leverage on is technology. As I said, not everybody will relocate. So we have to invest in mobile as well as digital technology, teleconferences, radio pathology. When you can do telepathology, I mean that you can ask someone that is not here, help you with things. You can do teleconferences. When you talk about knowledge and how to do things, once you set the processes in place, once you set the standards in place, and you try as much as possible to enforce it, we have very intelligent people back here in Nigeria. Things will fall in place, and things are already in place anyway. So I just think that we need to organize within and outside, those in diaspora, those of us and those of them that are here, marriage our efforts together to improve healthcare in Nigeria.
Let's talk about research. I'm not sure, I don't know to what extent we've gone on that road, on the road of research, but what have you seen? What do you know in terms of what we're doing, or how far we've gone as far as research is cancer research now?
There are some cancer research being done at the grassroots level. Also, there are individuals in diaspora that are bringing their research to Nigeria. Because the nice thing about Nigeria is that where else in the whole world will you find 200 or 150 million blacks or African Americans? So even, I will use the US for example. There is an issue of disparity as well as lack of data on blacks. So people across the world can learn a lot from us, and they want to come and do research here. We need to put the infrastructure in place. And with the connection as well as the knowledge that many Nigerians practicing all over the world have, we need to leverage on that, because people outside this country don't have what we have here. We have Nigerians, we have blacks, we have the gene, and they don't have it. So they need to do studies here, and we have to make sure that these are studies that will meet international standard, and the equipment and the people that are going to do it, they are already here. We just need to organize to do this. Okay,
and Dr. Onitilo, we have about 3 minutes left. I want to take you back to the issue of private sector engagement, private sector capital. Is there an example you can give us, maybe how it's done in the US, that can help us here in Nigeria to unlock more capital, to attract more private sector into the healthcare system?
The US is a capitalist society, and money talks. So most things are not government, is capital. Nigeria is a little different. However, we've also realized that the amount of the GDP or the budget apportioned to healthcare is not that much, because we have infrastructure and recurrent expenditures in this country. The private sector private sector don't do anything for free. Yes, there is some aspect of altruism and giving back also, but they have to be profitable. So I know that there are some private sectors that are trying to go in the way of cancer, for example. Afrexim Bank are doing something, or they already have a land given by the federal government in Abuja. And when the private sector come in, that is when you have development. That is where you have standardization. You think about the banking industry in Nigeria today. Think about the telecommunication industry today. It's because they are privatized that we are where we are. Government has its role, but we cannot leave everything to government. The private sector needs to know that money can be made in healthcare. I'll give you an example. When people talk about foreign aid, government aid, the largest aid to Africans or Nigerians is coming from Nigerians. For example, the last figure I saw is about 6 billion. It's being given, it's money that is being remittance to back home. So in the private sector also, they can make money in healthcare. Okay. And they should really think about cancer care, because cancer is here, is emergent, and we need to tackle it right, by it's like holding the bull by the horn.
Dr. Onitilo, I must thank you for your time today. Thank you so much for being on our program today and sharing all that insight with us today. I've been speaking to Dr. Adedayo Onitilo. He's a service line director at Marshfield Clinic Health Systems, and we're looking at how to improve health outcomes in Nigeria. Well, that's a wrap on today's edition of Beyond Markets. Thank you so much for being a part of it. Remember that you can watch the show at 5 p.m. West African time daily and have access to all previous episodes of the show on our website at cnbcafrica.com. You can also stay engaged with the hashtag Beyond Markets, and of course you can send tweets to my Twitter handle too at Esther or Awoniyi. From myself and the team, it's bye for now.